Welcome to the third event of this year's Children First UNICEF Speaker Series. I'm Barbara Eisenson, a co-chair and co-sponsor with Barry Landry of this series, and a member of the New England Board of the U.S. Fund for UNICEF. Thank you to all of you for coming, and to our committee members, and especially to our fabulous colleagues at the Boston Regional Office for UNICEF, who, with their endless hard work, make this happen every single year. This speaker series seeks to introduce you to all the myriad ways that UNICEF puts children first, by bringing in individuals whose lives have been touched by UNICEF, as well as those who do the work in the offices and in the field, and others whose goals support and intersect with those of UNICEF. We hope that you enjoy the program today and that it inspires you to get involved and spread the word about UNICEF's life-saving and transformative work. Today we'll have a slightly different format from our usual one. We're very pleased to have two speakers with us. First, you'll meet Michael Grodzinski, who is Director of Fundraising Partnerships and an expert on UNICEF's campaign to eliminate maternal and neonatal tetanus. Then Michael will introduce our special guest, Carrie Rhodes. We encourage all of you, as you listen to the presentations, to think of questions for either Michael or Carrie. We look forward to having a very interactive discussion during the Q&A at the close of our program. Now to tell you a little bit about Michael, a native of Watertown and an alum of BC High in Dorchester. Welcome home. We still have some snow for you. Michael first joined the U.S. Fund in 2011 to help manage the Eliminate Project, Kiwanis International's global campaign for children, which supports efforts to eliminate maternal and neonatal tetanus in partnership with UNICEF. Michael has led donor delegations to the field to witness MNT elimination programs and sustainability in Guinea, Madagascar, and Indonesia. Please welcome Michael Grodzinski to tell us more about this life-saving work.
Thank you so much, Barbara, for that very kind introduction and that welcome. So I'd say good afternoon to you all. Thank you so much for having this speaker series. Thank you so much for inviting me back home to Boston, my hometown, to talk to you about a very compelling program and project. I'd first like to express my sincere thanks again to Barbara and to Barry Landry and the entire Children First Speaker Series Committee for hosting today's luncheon. I'm grateful for their leadership and for the generosity of the entire New England Regional Board of Directors. Today's keynote speaker, Carrie Rhodes, is an amazing individual whose philanthropic generosity is outdone only by her unyielding passion to do whatever it takes to ensure the survival and development of children everywhere. Carrie puts children first, and she and her family have done so primarily through their support of the Eliminate Project. Exactly. I'd like to offer some context about the issue and how UNICEF and partners are protecting babies, are protecting mothers, and are saving lives. The problem with which we are dealing is maternal and neonatal tetanus, or MNT. I'm sure that many of you know about this, but I'd like to give you a brief overview of the program and what UNICEF is doing to save the most marginalized families around the world. Now, most people in the United States, in Europe, in Canada, etc., have never heard of this disease. But the distressing reality is that this disease is killing moms and babies in some of the poorest and hardest to reach areas around the world at an alarming rate. Now, the vast majority of tetanus cases worldwide are not the result of cutting oneself on a rusty nail or of an accident at a construction site. More than 80% of tetanus cases worldwide occur in mothers and newborns. Tetanus is caused when bacteria found in soil everywhere enters the bloodstream through an open wound, such as the cut end of an umbilical cord. Women and newborns are especially at risk during and after childbirth due to unsafe birthing practices and unsanitary conditions, especially when the umbilical cord is cut. Most mothers and newborns who die of tetanus live in sub-Saharan Africa and Southeast and East Asia, where many women are poor and have limited or no access to hygienic healthcare services. Known as the silent killer, tetanus strikes mothers and newborns at home where both the birth and the deaths often go unreported. When a baby is infected with tetanus, a lethal toxin attacks his or her nervous system, causing excruciating spasms and repeated, painful convulsions. The newborn will stop nursing and then will become highly sensitive to light, to sound, and to touch. Even a mother's voice can trigger convulsions, leaving the mother incapable of soothing her own child. And she has to watch as her brand new baby suffers and usually dies. It is one of the most awful deaths possible, and it is happening right now to babies and mothers with an unacceptable frequency in the developing world. Approximately every 11 minutes, a baby dies from neonatal tetanus. It's 134 every day, or 49,000 every year. But why? Why do we still have a problem like this when we've had a vaccine for over a century? Poverty. Poverty and lack of access to basic healthcare services. Lack of skilled healthcare workers and birth attendants who can provide quality delivery services. Lack of education. Lack of information about tetanus and unsafe local delivery practices and beliefs. For example, in some cultures, cow dung or mud is applied to the umbilical cord stump with the belief that it keeps spirits away. Or, as we see here, a Karamojong man in Kenya mixes water and cow dung on the dirt floor of his family's compound, which creates a smooth surface on which to dry harvested grain. This is great for drying grain, not great for a woman who has to give birth on that same floor. And these are the kinds of environments that are conducive to tetanus. And lastly, geographical challenges. Women and newborns most vulnerable to MNT are often the hardest to reach. But it doesn't have to be this way. MNT is completely preventable. Though highly fatal once contracted, the good news is that UNICEF has a time-tested strategy in place to prevent all this tragedy. 3 properly spaced doses of an inexpensive immunization can protect mothers, who then automatically pass on their immunity to their newborns. How do we do this? How does UNICEF implement this strategy? Immunizations. The Eliminate Project focuses on supplemental immunization activities in high-risk areas for MNT, targeting the most marginalized and neglected women across the globe. UNICEF and its partners go where immunization programs don't exist, where they may be poorly managed or difficult to access. Women receive 3 doses of tetanus toxoid with an interval of about 4 weeks between doses 1 and 2, and about 6 months between doses 2 and 3. But not just pregnant women, all women of reproductive age who live in high-risk areas for MNT. With the support of trained community volunteers, health workers, and people known as social mobilizers, information about the immunization campaigns is spread throughout the targeted communities during home visits and by other means. And when the right people act as social mobilizers at the right time, you can get the entire village to show up for an immunization campaign. UNICEF also works with local leaders to change societal norms and to educate the entire community, including men, on how easy it is to prevent diseases such as tetanus. By increasing understanding, we can generate demand for MNT elimination activities and other antenatal care services. The work does not stop when elimination is reached. Strategies and partnerships are put in place to maintain protection against tetanus. Education plays such a critical role in promoting clean birthing practices and proper umbilical cord care. When women are vaccinated against tetanus and learn about maternal health, they become empowered to take care of not only their health, but the health of their newborns. Now, how much does all this cost? How much does it cost to get a vaccine all the way from the manufacturer to the most remote places on Earth? How much does it cost to train health workers? How much does all of this take? $1.80. It takes just $1.80 to protect one woman and her future newborns against tetanus. $1.80 provides injection supplies, the vaccine itself, syringes, planning and training for health workers, advocacy and community outreach, transportation, and more. I challenge you to find a better return on investment. This is the power of UNICEF. We deliver results at incredible scale. Now today, MNT persists as a public health program in 24 countries, mainly in sub-Saharan Africa and in Asia. Since global efforts were relaunched in 1999, UNICEF and partners have eliminated MNT in 35 nations. You can see that the pace of progress has picked up really in just the past 5 years, precisely when additional partners entered the scene and provided more funding. Now, the number of neonatal tetanus deaths per year has been reduced from 800,000 in 1987 to just 49,000 today. UNICEF and partners have reduced neonatal tetanus deaths by more than 90% in just the last 25 years. This is yet another example of the remarkable success of this program, but this program only works when there's adequate funding. Just 5 months ago, in October, we learned that neonatal tetanus deaths dropped by more than 15% in just 3 years, from 2010 to 2013, from 58,000 to 49,000. This is an incredible achievement, but it's only possible because of our partners, because of our donors. But this program works. But what I can't emphasize enough, as I've been saying, is that all this progress, all this success only happens when the funding is in place. We are so grateful to have so many wonderful and generous partners in the fight against MNT. Kiwanis International is an extraordinary partner who decided in 2010 to join UNICEF and help with the elimination of MNT. They're a wonderful organization of nearly 600,000 members around the globe who are truly helping to change the world, one child and one community at a time. I'm so pleased that a representative of Kiwanis International, Mr. Dan Bennett, is here with us today. Dan helps to coordinate Kiwanis' fundraising efforts in the New England region. Dan, would you mind standing up and being recognized?
Thank you, Mike.
And I would also really like to give warm recognition to our friends at LDS Charities, longtime supporters of UNICEF, who recently made an incredibly generous investment in the Eliminate Project, and who really changed the game for us at the U.S. Fund and UNICEF. We're so thrilled that our friend Jamie Glenn, who oversees immunization programs for LDS Charities, is here with us today. Jamie, can I ask you to stand up and also be recognized? Our sincere thanks to you and your whole team, Jamie. Now today, I have the distinct pleasure of introducing one of our greatest partners and friends. Originally from Wellesley, Massachusetts, Carrie Rhodes has traveled around the world and been long involved in global public health. I would say that her generosity of spirit and compassion is a family trait, for her entire family has given generously to UNICEF. Carrie has put children first, not only through incredible financial support, but through experiencing programs and contributing her intellect and energy to a variety of U.S. Fund and UNICEF endeavors. Carrie and her mother Jean traveled to Copenhagen to see our supply division and its global headquarters in October of last year. Carrie and her daughter Danny, who you'll hear more about, traveled to Belize in March of 2011 to see UNICEF's work as part of a parent-child trip. Carrie has previously served on the Development Committee of the U.S. Fund for UNICEF and is a current member of the Program Committee. While the financial support that Carrie and her family have contributed to the Eliminate Project has been the anchor of the U.S. Fund's commitment to MNT elimination, I would say that it is Carrie, Danny, and her whole family's willingness to repeatedly share their story that has been one of the most valuable gifts that the U.S. Fund has ever received. At the beginning of the Eliminate Project, the Rhodes family collectively committed $1 million as part of the U.S. Fund's commitment to raise $15 million for the Eliminate Project. But as credible as that has been, as much of the bedrock of our fundraising that the Rhodes gift is, the true impact of Carrie and her family's generosity is simply incalculable. A tireless advocate, Carrie has kindly accepted our many requests and pleas for her to speak to groups of friends such as everyone in this room. She has spoken at events for the U.S. Fund not only in her home of Seattle, but in Los Angeles, San Francisco, Chicago, Geneva, and New York, just to name a few. She has graciously done interviews and will be speaking again at a speaker series in Atlanta about 1 month from today. And then she's traveling the next day to the U.S. Fund's annual meeting in New York. Now, perhaps at this point you might be asking yourself, why? What would compel an individual and a family to be so passionate about one cause, about one relatively small disease in the whole spectrum of global public health problems? Now, you may have seen on today's program that Carrie's story begins when she met her daughter, Danny, who contracted and suffered from tetanus as a newborn. Carrie will share with us her inspirational story today. What I would ask of everyone is that, as you listen, remember that the story of maternal and neonatal tetanus is, at its heart, the story of the day of and first few days following the birth of a child. A baby who is so very vulnerable, a mother who is both excited and scared. MNT is the tragic story of a mom and baby who were put at risk simply because that woman did not have access to a little education or access to a few doses of vaccine that cost less than the price of a cup of coffee. But as I think you'll hear from Carrie, her story, and the story of the Eliminate Project, is that hope and progress are not only possible, they are real. What Carrie, the Rhodes family, our partners and donors like Kiwanis International and LDS have been making and continue to make possible is the story of hope. Hope that comes in the form of vaccines being delivered even under the most challenging circumstances. Progress that can be seen as country after country eliminates MNT, and as we see less and less babies dying every day. The story of the Eliminate Project is that we can efficiently save the most vulnerable lives when we put children first. Ladies and gentlemen, it is my honor to introduce to you a woman who has always put children first, Ms. Carrie Rhodes. Carrie?
Thank you, Michael. And thank you all for coming today. To hear about this cause that's so very... Oh, crap. I haven't even started, okay? But anyway, this cause is so very close to my heart. And I'm going to apologize ahead of time in case my son in the back there knows I'm up here and runs up. Which, Linda, it might be better if he just runs up than cries in the back. The first days of my daughter's life were spent in pain too terrible to imagine. Thrashing in agony in the arms of her birth mother. Convulsions that made her powerless to sleep or even to rest. Hungry and weak, unable to nurse with a jaw locked tight from tetanus. Hurting, helpless, and almost certain to die. It is those images that bring me here today. But it is also the image of my beautiful and healthy 18-year-old daughter, Danny. As she is today, many years after her earliest days in a Chinese hospital, a miracle of life and a symbol of hope that UNICEF, Kiwanis International, and the Eliminate Project will bring to generations of mothers and their children who are at risk for maternal and neonatal tetanus. As Michael said, today 49,000 babies and almost 5,000 mothers die of this disease, a disease that is 100% preventable. We know how to save them. All it takes is the commitment, the funding, the will. My own commitment to eliminating MNT began when I was just 24 years old. I had graduated from nursing school, and I decided I wanted to continue my education in third world countries, learning about traditional birth practices as I worked toward my long-term goal of becoming a midwife. I started out in a women's clinic in India, where poverty and a culture of male dominance often made delivery rooms places of misery instead of joy. I can remember holding one woman's newborn daughter, her fourth or fifth girl, without a son. And as her mother-in-law looked on, I cuddled this little girl and cooed to her and told him what a beautiful, wonderful little girl this was, how special she was. But when I tried to hand the baby back to her, the mother said, no, you keep her. Better to return home empty-handed than with another girl that could not afford to care for and the prospect of another pregnancy to provide the son that her family demanded. My lifelong dream to become an adoptive mother was cemented through that experience. I grew up with cousins and close friends who were adopted. I knew that adoption is a wonderful way to build a family. And my experience in India made me even more determined, not just to adopt, but to adopt a child from a country where I had worked. One day, I thought, one day when I'm secure in my career, when I'm married and settled in my own home, but one day came much sooner than I thought it would. After 4 months in India, I went to China to work in a hospital in the city of Tianjin, which is known throughout the country as one of the best children's hospitals in China. On my third day there, one of the other nurses, was walking through the newborn ward, telling me about the histories of the babies. How some of their families would travel hundreds of miles to bring their children to the hospital and leave them. They had to return home to continue to work, to be able to afford to pay for their care. Other parents never returned, certain that their children wouldn't survive, or unable to afford to care for them if they did. As I listened to these stories about each baby, we came upon one crib. Inside was a tiny girl who had been there for 2 months. She opened her huge brown eyes, and she smiled at me, and I fell in love. Her name was Li Dan, and I knew in that instant that we were destined to be a family. It gets harder each time I tell the story, so it's easier. Danny had come to the hospital when she was just 10 days old, barely weighing 4 pounds, suffering from convulsions and lockjaw. Most babies who contract tetanus die because they don't have access to the medications that a hospital can sort of feed into for nourishment until the lockjaw subsides. Even with the right medications and care, 4 in 10 babies who get neonatal tetanus don't make it. But fortunately, Danny received excellent care. And even though she was little, she was, and still is, a fighter. And so was I. At 24 years old, with no real job and no secure future in sight, I abandoned my plans for a career-oriented world tour to remain in China and adopt my daughter. Over the next year, there were countless hurdles in the adoption process. The hospital had to be sure that Danny's birth parents were not returning for her. They never did find them. Her birth parents never did come back. But I've always told Danny that they loved her. After all, they brought her to the best hospital they could find. But she was so sick, they were probably certain she would die. There were many people on my side through the long and agonizing months of waiting for the adoption to be approved. The hospital arranged to keep Danny instead of sending her to the orphanage. This was right after the BBC expose on the conditions in Chinese orphanages, and the government had shut down all access for foreigners to go to the orphanages. So had she been transferred to the orphanage, as she should have been, I wouldn't have been able to see her anymore. But she stayed in the hospital, where I was able to visit her once a week. And I would bicycle to the hospital with baby blankets and big bags of diapers hanging from the handlebars of my bike and from my shoulders. I brought in English story tapes and music tapes to play on a big blue box when I wasn't there so she could hear English. And when I was there, I held her and read Winnie the Pooh over and over again. Gradually, I saw Danny change from an infant only barely recovered from the devastating start in life to a curious, smart, charming, happy, and healthy baby girl. She and I never gave up, and the day her adoption was approved was one of the happiest days of my life. We came back to Seattle to begin our lives as a family. It was about 2 years later when I opened my mailbox to find a fundraising letter from UNICEF. I had known about UNICEF all of my life. I grew up in Wellesley, trick-or-treating from UNICEF every year. And so when I received this letter announcing the campaign to eliminate MNT, I knew I would do whatever I could to raise awareness and money to eliminate the disease that had always robbed me of my little girl before I ever got to be her mom. Since then, I've eagerly followed the progress that UNICEF has already made in eliminating MNT from 35 countries. Only 24 left. As Michael said earlier, compared to many other diseases, it's easy. It costs just $1.80 to vaccinate a girl or a woman against tetanus and to provide education and training. Once they're vaccinated, the newborn children are also protected. Mothers live, babies live, and the whole family gets a fighting chance to thrive too. Research shows that children who grow up without a mother have a much higher risk of hunger, illness, and illiteracy than other children. With a healthy mother, children have a much better chance of escaping the cycle of poverty. And the Eliminate Project is ensuring that this relatively easy solution is brought to the most difficult of places, to areas of conflict, to remote villages, to countries where culture poses a barrier to modern medicine. Over the next few years, the disease will be virtually wiped out. I know that my daughter went through unimaginable pain as she lay in that Chinese hospital 18 years ago. When I gave birth to Danny's little sister, Lily, 12 years ago, a healthy 8-pound baby who I could hold and comfort and feed. And again, 18 months ago, when my son Eli was born, I could finally begin to understand the pain that Danny's birth mother must have gone through. To hold a child in your arms who screams in pain at your touch. A child you know is starving, but who you cannot feed. A child you're sure is dying, with no way to hope, no way to help. No parent should see her child suffer like that. And with the success of the Eliminate Project, none ever will again. From the bottom of my heart, thank you.
So I think we can open up to a Q&A if anyone has any questions for Carrie or for myself. I've never known the people of Boston to be shy. Oh, there we go.
It seems like such an obvious, set of solutions to solve this problem. What is the biggest obstacle at this point?
That's a great question. Thank you so much. It does seem obvious because it is. Because we've done it, because it is time tested, because it is exceptionally well proven. But the obstacle, quite honestly, is funding. It is lack of funding, it is lack of timely funding that prevents countries from buying the vaccine, from maintaining cold chain services to keep that vaccine cold as it's delivered all the way, even under some very challenging conditions. And it's also because of who it affects. It affects the poorest of the poor. It affects the most marginalized women and babies who have no voice. Because the deaths, the 49,000, that's an estimate. There's a global estimate. The reality is it's probably higher. These deaths go unrecorded because most often the births go unreported. These are women and children who live beyond the reaches of traditional health services, routine immunization services. These are women and babies and families who no one ever hears about. But that's what UNICEF and its partners are helping make possible. They're trying to bring awareness to people, such as everyone in this room, about this issue. But to be quite honest about it, the main obstacle is the lack of funding. Yes, Barbara?
Could you explain a little bit how we piggyback on programs we already have in place, like the polio programs, and so once you have an inroad somewhere, you use it for all the immunizations?
Sure. So on the question of, is the tetanus immunization campaign integrated with other health services? Very much so. Either, depending on the local context, sometimes where there have been inroads already made, say for another immunization campaign like measles or polio, for example, that same healthcare infrastructure, those healthcare workers, those are used to deliver the tetanus vaccine. But quite often what is the case is that tetanus is the first inroad into some of these communities. Again, the communities, it's not every woman in a country that's at risk for MNT, but in the high-risk areas, again, those areas beyond the reach of routine healthcare services, those are the ones who are at risk, and the tetanus campaigns are often those first inroads. When I was in Indonesia in September, not only did we see a tetanus campaign, but one of the ways that UNICEF works to get women to show up in the first place to receive their immunizations, women they'll come if it's well publicized, well promoted, but the one thing that will get every woman to show up is if we provide services for their kids. And so by providing vitamin A, by providing deworming tablets, by providing free mosquito nets, women will bring their children for those services, and often in communities where having multiple children is the norm, those women will come to an integrated, for example, like a National Health Day or National Immunization Day. I was on this island in Papua, and we were at this, it was just really a bunch of sticks holding up some boards right on the coast of this lake, and there were malaria nets, there was polio vaccine, there was vitamin A, and there were tetanus vaccines for the women. And every woman got her immunizations, but by using integrated services, that's how you get everyone to show up.
The other thing on that is that while here tetanus is unheard of, we all get our boosters when we step on a rusty nail or something, but for the most part, nobody gets tetanus here. But in these areas, everybody knows tetanus. When Danny was brought to the hospital, the staff immediately knew what the problem was. Her parents knew what the problem was. The staff knew what to do and hoped it would work. When you're able to tell people that we can prevent this, they know exactly what we're talking about and will come.
For the most part, are the vaccines delivered by local doctors, nurses, etc., or are the care provided outside of this?
Sure. One of the, I'd say, the unique value adds of UNICEF is that we work to build the capacity of local healthcare workers, local government officials, really the people who live in the country. And so the tetanus immunization campaigns, it's not a bunch of people from UNICEF flown in from around the world. Rather, it's the UNICEF staff. In any UNICEF country office, the staff is comprised of at least 80% of country nationals. And UNICEF in each country is a part of the community because they're staffed by the members of the community. And so what we do is we train the local healthcare workers in best practices, and they are the ones who go out, educate their own community members. And often the healthcare workers, they're either elected or appointed by their communities. It's seen often as a position of honor. And they are the ones who deliver the vaccines. They are the ones who are promoting it and maintaining the health education throughout these communities.
Just to add, I think one thing that is always left out of this is education. I was in 2013 at a conference in Africa where we were looking at adding. One of the things that misses in this is education, and we fail to educate even primary school children on the diseases in their communities, just as we educate them on many different things. I was in a curriculum building meeting in one of the countries of Africa, and we were fighting just to put childhood diseases in the curriculum. And my say is we got to put it in primary school education, because in many of our countries, even if a girl does not finish school, she may get up to grade 4, grade 5, or grade 6. And if we put it right there, the children start knowing this, because by that time they're learning things in rhymes and stuff like that, in songs. We are going to get further on. The other thing that I think we are being kind to talk about is our own governments. I'm African, so I can say that. There is no reason why in our own governments we take some people to be less than others. So if we have to eradicate illness, and we have done so with many other illnesses, then there is no reason why some illnesses have to be left behind and some people have to be left behind. And I just think when big NGOs deal directly with the government, sometimes we gain, but many times we lose. All this work starts with the grassroots most of the time. Thank you.
Thank you. Other questions? Yes, miss?
Is there a window of time when the baby needs to be seen before it's?
So I'll just try to repeat the question for everyone. The question is there a window of time in which the newborn, once the newborn's contracted tetanus, needs to be seen before it's too late? So tetanus is known, it's a very ancient disease, and it's actually known as the 7-day death. It's referenced in the Old Testament. And so often the point of infection is the day of birth, when the umbilical cord is cut. And anywhere from the first week to, depending on the situation, to 2 weeks, really. It's really the first month of life. The reality is that if a newborn is born in the conditions that give rise to tetanus in the first place, the fatality rates can be high as 100%. It is usually a death sentence because, with some exceptions, and fortunately for all of us, that Danny was born in an environment where there was actually a proper children's hospital nearby, but most communities who are at risk of tetanus don't live anywhere near what we would call a proper medical facility. So in some senses, that if a newborn contracts tetanus, it's almost usually too late at that point. Now, it is possible to survive, but again, you really need proper medical facilities for that, and that's why the fatality rates, once contracted, are as high as they are. But that's why, again, the emphasis that UNICEF places is on prevention in the first place, the proactive solution. Yes, please.
What countries have the highest rates of tetanus still, and why is that?
You wave your hand, I didn't see who was asking. Oh, okay, very good. Countries with the highest rates of tetanus. I mean, it wouldn't surprise you that some places like Chad, South Sudan, parts of India, parts of Pakistan have some of the highest rates. But again, to look at it from a country by country level, I don't think really portrays an accurate picture. Again, it's not, for example, that map that we showed, to look at one country, for example, Ethiopia. Ethiopia has eliminated MNT in almost every province except for one, from the Somali region of Ethiopia, which is on the border of Somalia, is the most remote, most impoverished. But the reasons why the rates are such that they are, it sounds cliche, but it's the poorest of the poor, it's the most marginalized, it's in the countries that don't have the basic health infrastructure and the routine immunization services to reach all of these women and their families.
Actually, I've seen how touched you are with what you are telling us. And I believe one reason of that is that you were in the field with mothers. So I'm calling like all donors to go there and see closely the children and their mothers. And I'm calling and see this opportunity to remind all of us, children in Yemen are being died from tetanus, but at this moment are being died or being killed with no reason. So please look at Yemen at this moment.
I'd actually like to make a note about that, and thank you for keeping our attention on the ongoing conflict. But in terms of timing in this program, so we've been talking about Yemen to a lot of our friends and donors recently. A few years ago, maybe in 2010, 2011, Yemen had in place a strategy to eliminate MNT, had the program in place, knew what to do, knew who the women were in high-risk areas. But there was one thing preventing UNICEF and the local government at the time from actually implementing the plans: money, lack of funding. And so had UNICEF had the funding in time to keep the 3 rounds necessary to immunize women, we would have been able to protect a generation against tetanus. And as awful as what is happening right now in Yemen is, and the complete lack of stability, the collapse of the government, and the current fighting, as awful as that is, at the very least, we would have been able to protect a generation of women and their future newborns against tetanus. But because we didn't have the money at the time, we weren't able to act. And so, again, just want to emphasize that all the progress, again, this is one of the most successful global public health programs that UNICEF has, but all that progress comes from our supporters, the people who have heard this story, people like Carrie and her family who know what tetanus really does and what it does to families, and are help making progress possible. Yes, ma'am.
Is there research going on to make this a one application? Where it seems like having to wait for 6 months, particularly in a stable environment, would make it hard to find a person who will last.
Sure. On the question of innovations and what's the future of tetanus immunizations, the doses, that's going to be a mainstay for a while. I mean, even here in the United States and in the developed world, you still need, in the ideal scenario, is that through your lifetime you get 5 doses, but you get 5 doses of a combined tetanus, diphtheria, tetanus, pertussis, DTP vaccine. And so it's really the future's in combination vaccines where you don't have to do all these single antigen immunizations. One thing that would make immunization campaigns easier in the harder to reach areas is moving from a traditional syringe or an auto-disable syringe, which sort of self-destructs after you use it one time as a safety mechanism, to a pre-filled syringe called Uniject, which is actually manufactured by one of our partners, Becton Dickinson, which would enable people to administer the vaccine without any kind of training. So there are innovations currently being developed and research trying to scale it up, but in terms of the dose spacing, I think that's going to be with us for a while, just based on the epidemiology of the antigen.
I'm wondering in terms of funding, am I correct, when you call it eliminate, it's not, it doesn't sound like it's the kind of eliminate that polio is, right?
Yeah.
It's something you have to, wherever you've gone and been successful, you have to stay there, right?
Sure.
So that's, must be, in terms of funding, a tricky thing, you know, to have, it's not like you can go there and help the moms, the babies that are sick now or potential, and then move to a different country or a different location. You've got to stay there and continue to vaccinate other girls. Right?
Sure.
Forever.
No, that's true. And so that's really two questions. And just on the difference, why we keep saying eliminate, not eradicate, like polio. Polio is a virus. If you actually, immunize everyone against polio, the virus, without a host, it will actually die. And that's only been done once in human history. That's with smallpox. So smallpox no longer exists. And the same will be true with polio once you eradicate. Tetanus, because it's bacteria, it's present in soil everywhere, will never be completely rid of the actual bacteria. And so once you immunize women of reproductive age, as you said, with the doses, you will continue to have to immunize women, you'll have to immunize kids, and the transition to sustaining those gains that you make through the Eliminate Project is by scaling up routine immunization services. But that's why the outreach into these communities is so critical, because you're establishing those linkages with the communities that have had no access to health services, and once they know those services exist, that creates demand. And once you have demand, that empowers the local authorities, the local government, to expand their reach, to scale up routine immunization services. Another thing I would say that in the past 15 years, of the 35 countries that have eliminated MNT, not a single country has gone back on the list. This is an incredibly sustainable program, which speaks to the power of UNICEF's larger routine immunization program.
Anyways, can I ask a follow-up?
Sure.
The countries that have continued to be off the list, is that because the government has taken over the job, or does UNICEF have to continue? Just in terms of funding.
Sure.
Is what I'm asking.
Sure, it really depends on, it's a country by country context. In some countries, for example, middle income countries like Indonesia, which is close to eliminating MNT. Indonesia has more resources, is wealthier overall in the aggregate. And so they're taking on and paying for more of the routine immunization services, and their UNICEF more helps with technical capacity and giving advice on best practices. A country like Guinea, for example, UNICEF does more of the work on the ground and paying for things, but over the long term is transitioning from being the service provider and paying for things, bringing in things like vaccines, to the government. But since UNICEF's there for the long haul, we're constantly working with our government partners to transition for eventual ownership, but it depends on the country by country situation.
And that's part of UNICEF's goal overall, is to put themselves out of business, to get the government supporting the programs themselves and running it, so that there's no need for UNICEF.
Yes, ma'am.
I went for UNICEF in Ghana, and I just wanted to buttress the country. That's when UNICEF works upstream, we say upstream, at the policy level.
And downstream, and that's at the community level. So with new innovations, we need to replicate for government to have confidence that this really works. And once they pick it up, sustainability is attained. So in some countries where you find sustainability and where we say it's eliminated, it's at the level where the government has taken over and made it part of their immunization stream. So when their volunteers in the community level, their health workers go out, it's a part of the immunization they will give to women. And that's when we say it's sustained and eliminate. And UNICEF may only bring in the vaccines and periodically some training, but it's taken over by government.
Any other questions? Comments? Yes, ma'am.
In countries where you've had success, well, when you start talking about this, you're getting them on, when in the countries that you're sort of initiating this and you're trying to, get confidence in the program and everything, you're vaccinating women who've already had children. And because they show up because of kids. But in an ideal situation over the long term, are you, in the countries that have had success, are you rolling this back so that you're vaccinating younger, the girls? So this is all done before they get married or have children, or is there like a model that you're following to sort of roll it back to school age?
Yes.
That's a really good answer.
But I can elaborate a little bit, than just saying yes. When I was in Indonesia with some donors who support the Eliminate Project, we went to Papua, where we both saw the door-to-door immunization services, literally going from hut to hut to make sure and double check. We all were double checking, interviewing women about have you received your vaccine. But then we went to another area where we went to some schools, and we went to a middle school where young girls were getting immunizations. So we even saw elsewhere in the country, part of the country, again, it's very district by district, region by region within a country, especially a country as large as Indonesia, where in some areas they were getting the vaccine to the girls who were just entering puberty and really becoming, at the beginning of the spectrum we think of for women of childbearing age, the global average of 15 to 49. That's the age range we think of for MMT. And again, that's, 15 and 14, that's young, but we tend to be cautious about these kinds of things. And so we immunized them, but we also saw primary schools where kids were starting to get their initial shots, boys and girls, in terms of that's the routine immunization services part. And so in terms of sustainability, the Eliminate Project makes those first linkages, protects women, protects that generation, but creates the linkages so you keep delivering routine immunization services. And that's the long-term vision, that everyone everywhere gets access to the routine immunization services, so you're not playing catch-up to a woman who is 25, 30, 35, who maybe has never had access to immunization before. You're integrating it into the very first months and days of life. That's the long-term plan. Any questions? Well, I think I'm going to turn it over to my friend and colleague, Matthew Payne.
Hi, my name is Matthew Payne. I'm the Managing Director of the New England Region for UNICEF, and thank you all for being here. First of all, I want to thank Carrie for being with us here today, and Eli too. I'm not exaggerating when I say that since I've been involved with US Fund for UNICEF, which has been 8 or so years now, Carrie has been on our speaker list for that entire time, and I'm just thrilled that we were able to make this happen today, so thank you for being here. I also wanted to say thank you too to Michael for coming home to Boston and joining us today. As you can tell, he is incredibly passionate about this cause. Incredibly well spoken. It's hard to speak after him, actually. It's really unfair. It's never switching us. But I'm so honored to have colleagues like Michael and so many others. So thank you for being here too. Also, I wanted to thank Dan again for being here and representing Kiwanis so well. The leadership that you have shown has been very incredible. And also LDS and all of our other partners, so thank you for being here. As you might have noticed, Michael mentioned that most of the time, most of our staff in the field is actually people from those countries. As you might have noticed, we have several of those folks here today, and I wanted just to have them stand up. We have, at this time, we're in our first cohort of child protection fellows that are studying at the FXB Center at Harvard in partnership with UNICEF. And so here in the room today that you've already heard from, we have Noor from Yemen. Could you stand, please? Amelia from Ghana. And Sumit from the back. From Cambodia. And I wanted to acknowledge them and just make sure that you knew they were here, because really the work of UNICEF is done by these folks. And we're so honored to be able to have the opportunity for them to be in Boston this year, to be a part of the Harvard program. And we're very much looking forward to seeing more of your work after you're back home. So thank you for being here. I also want to let you know about some of the other things that are happening in Boston, since I have a moment. One I'm most excited about, you might have seen it already in the news, Channel 5 and the Boston Globe. For this past March and April, over 4,200 children here in the Boston area have been generating kid power. If you don't know what that means, these bands, and there are others around here, I see other hands, yes, we have many bands, make it possible for a child in Massachusetts to get active and get themselves up off the couch and doing things, but as they do that, they're literally saving the lives of malnourished children all around the world. And in fact, as of this morning, and these are going to be updated already, I know, so I'm out of date when I say this, but as of this morning, Boston area kids have walked 167,000 miles and provided over 38,000 packets of ready-to-use therapeutic food for malnourished children who need it. It's just incredible numbers and really amazing to see this program in action. So you can go to unicefkidpower.org for more information or ask anybody who's wearing a band. Also coming up, Patriots Day, April 20th. It's terrifying to even say that, it's 2.5 weeks away. Team UNICEF will be running in the Boston Marathon. We are very, very excited about that. Two of us are in the room actually, so that's why I'm so terrified, and myself. So I hope if you're around you'll be able to cheer us on and look for the UNICEF blue shirts. I also hope you can join us on May 14th, which is when our next and last speaker series event for the year is going to be. We'll be featuring Alex Euster, who leads UNICEF's work on social inclusion, child poverty, and discrimination. These issues really get at the heart of UNICEF's forward-thinking work, and this will be a great opportunity to learn more about that work. So I hope you can join us, May 14th. In closing, I want to thank and acknowledge our co-chairs of the committee, Barry Landry, Barbara Eisenson. Thank you so much for all that you do to make these events so successful and for your sponsorship of this series this year. Thank you too to the Northern Trust Company, which is providing additional support this year. And also to the many members of the committee who have the blue ribbons you'll see around the room for everything that they do to make this work. And finally, thank you for being here and taking time out of your busy day to learn about this incredible partnership and the work that needs to be done. So please, feel free to stay, enjoy the cookies and the coffee. Happy spring. I never thought I'd be able to say that. And thank you for being here.